Thank you guys all so much. And I'm going to open this up now to questions. And while people are thinking about it, I'm going to go ahead and start and just ask actually each of the panelists to talk. We've talked actually even in the session previously about individualization and where that might belong in a clinical practice guideline. And I'm wondering if you could comment then specifically on preoperative factors and the role of adjunctive anesthesia, which is really before we would talk about prescribing in these settings, and how those might be standardized within a clinical practice guideline in your specialty. So, Brian, if you want to start.
Sure. So I guess maybe I'll take each of the components separately. So with regard to the second point, I mean, I think certainly after delivery, but for many other acute indications for opioids, there's good data to support the role of non-opioid analgesics, and probably that should form the backbone of the analgesic approach to most conditions before opioids are used. And I think in obstetrics, really the thinking is shifting. Instead of opioids being the primary approach to analgesia, opioids being thought of as rescue medication. Certainly that's what we're doing in our clinical practice, where we go to NSAIDs and acetaminophen first, and then only use opioids if patients have pain that is not well controlled with that approach. With regard to the second point, I tried to highlight in my talk. I think there are a number of studies coming along showing that a very useful strategy to avoid overprescribing is to take into account patients' preference, to take into account what patients are doing with respect to opioid use in the hospital, and informing what they're prescribed at discharge. That may not work in every clinical setting. If someone's in the ED, you're not going to be able to observe what they're requiring, and for opioids, it may not work in the primary care setting as well. But I think for post-surgical prescribing, shared decision-making, algorithms that incorporate patient-specific factors, pain scores, opioid requirements are going to be very helpful.
So again, I think tried to address it just a little bit. It's the multifactorial nature of what goes into patients that, at least the patients that I operate on, makes it a little bit challenging. We're certainly working, we believe, on algorithms to look at this. So we are looking at patients' behavioral situation. So we know, for example, as I alluded to, that patient activation, resiliency, we measure all of these things and we are trying to apply them. We're trying to apply patients that have been on opioids. We're looking at whether opioid holidays prior to surgery, all these types of things make a difference. The problem is what I can do at Dartmouth isn't generally applicable to what most people are doing. And my patients fill out form after form after form. I have the biggest patient-reported outcome database in orthopedics. I have 15.5 million separate answers from patients. I have one female patient, that's answered 7,752 questions during her career at our hospital. So the hard part for me is taking that and then applying it in a generally applicable way to everybody. And that's what's really challenging. The more questions I ask, I think I'm able to individualize and personalize this for a patient, but I don't think everybody's got the time to ask all the questions that we ask.
Yeah, my group of patients is a lot easier than what we heard about this morning and what David and Brian spoke about. My gut feeling, based on a lot of research and clinical experience, is about 80% of these dental impaction patients will do perfectly fine on an NSAID or an NSAID plus acetaminophen and dose it around the clock for the first day or two, and then go to PRN. But there is that 15 to 20% that legitimately need, on top of that NSAID, a short course of an immediate release acetaminophen plus opioid combination. And when I say short course, I'm talking about a max of 2 to 3 days worth. So I'm not talking about, 30 or 40 pills. I'm talking about maybe 10, 15 max. I've had the luck of working with, for the last 3 years, people from Garrett Fitzgerald's group at the University of Pennsylvania. Garrett is the one that first reported that celecoxib and rofecoxib was making platelets aggregate in the test tube. He's also responsible for the low-dose aspirin NSAID potential interaction, where NSAIDs may inhibit the cardioprotective effects of aspirin. And we have been looking at biomarkers that can potentially predict who those 80% are going to be and who those 20% are going to be. So we've been looking at things, and we just published a paper in Clinical Pharmacology and Therapeutics. But we've been looking at things like inflammatory mediators and genomics, high-throughput RNA sequencing. High-throughput RNA sequencing, just like fMRI brain imaging, wasn't a twinkle in my eyes a few years ago, but now it is. And right now, those type of tests would be very, very expensive. But, technology is really, really moving, and it may get to the point where you could take a buccal swab or a spit sample and actually have a good idea who those really, really good responders to NSAIDs are going to be pre-surgery. And we'll see where that research leads us.
Thanks. Dr. Weissman?
I'm sorry, I didn't take it down.
Okay, great. Dr. Walji?
Thank you so much for your presentations. They were fantastic and really informative. A couple of you touched on the different mechanisms for which pain comes about, and I wonder if you could talk a little bit about that from the lens of how we should consider clinical practice guidelines, how we should select procedures or groups of procedures that may hang together in that way. We've seen some spillover effects in prescribing guidelines that are applied to one procedure and then how they get applied to other procedures, and any other considerations about how surgical procedures may hang together, so to speak.
So I think I'll start. So I alluded to the fact that we need more research in nonsteroidal anti-inflammatory. So we like to use nonsteroidals. There's obviously the cardiac concerns. The other real concern, there's two other real concerns in orthopedics, in total knee replacement specifically. One is we have all of our patients on VT prophylaxis. So the addition of a random nonsteroidal anti-inflammatory medication may lead to other unwanted effects, gastric, other potential things. So that's problematic. So we need better studies to look at all these things put together. And then the other real one in orthopedics and in total knee replacement, again, is that a certain percentage of the total knee replacements we do are done without bone cement, and they have bone that grows into the prosthesis. And there is concern with the use of nonsteroidal anti-inflammatories based on some animal modeling that when you use nonsteroidal anti-inflammatories, that bone ingrowth is inhibited because that is an inflammatory process. So the reason why we just don't all jump ship and just say we're going to go full nonsteroidals is there are potential downstream effects of doing nonsteroidals. That's why long-term studies really are what we need. And we really need to be able to assess the whole safety profile across not only the perioperative period, but a longer period of time.
Dr. Delgado?
I think in this session and in the previous session, there's a lot of evidence presented on the efficacy of NSAIDs and using that in multimodal analgesia, either before or in combination. When the rubber meets the road and the prescriber is prescribing, you have the option of prescribing, either hydrocodone that comes with acetaminophen, oxycodone that comes with acetaminophen. So, 5 milligrams of oxycodone that comes with 325 of acetaminophen. Or you have the option of, say, prescribing 5 milligrams of oxycodone by itself and then telling the patient to take, say, 2 extra strength Tylenol and NSAIDs first, and then take the oxycodone as needed as a rescue sort of medication. And my question is there enough evidence or to suggest that when prescribing opioids, whether the opioid should be separated from the acetaminophen in the prescription, so that they maximize their non-opioids first, and if they're still having pain, they take opioids as rescue therapy.
Well, let me butt in on that. So there are really kind of two lines of thought on that. One is taking them together, you're going to have dose convenience. But if you do separate them, the patients are psychologically no more than 2 or 3 hours away from their next dose of analgesic, and I don't think that has been well studied. The other thing I want to bring up is that while I've bashed oral surgeons in my career for overprescribing immediate release opioids based on the data out there, they are prescribing when the patients are still numb, and they're prescribing for the worst case scenario. And they don't like getting that call. And now with the restrictions on calling in acetaminophen with hydrocodone and oxycodone combinations, it makes it more difficult. And then you say, okay, well, we'll go to the codeines and the tramadol combinations of the world. Well, those are the ones with the metabolic issues, where you have the slow metabolizers and the ultra-rapid metabolizers. So it becomes really problematic.
Dr. Karras?
Thank you, and thank you for all the great talks. I wanted to talk about total knee arthroplasty and implementation, because it sounds like even if you had all of the research answers that you'd wanted, you'd still be concerned about implementation. And so I wanted to toss a couple things out there. I don't have opinions. I'm interested in yours, but when we see some tools for implementation, whether it's pocket cards, easily accessible handouts, things to facilitate, prescriber use or of different interventions, or are you maybe in favor of something more comprehensive, like the only analogy I can think of right now is like antimicrobial stewardship, where you have more of a program where the guideline is going to recommend a program. So I'll let you go from there.
So I think it's probably more the latter is what I would advocate for. So shared decision-making is another Dartmouth thing. We don't use shared decision-making as we originally described it. We don't do that anymore. Get lots of reasons for that, but it gets into the George effect. So whenever we developed a really good shared decision-making program, what we learned is it only took one person to say something different than was in that, and the patient was more likely to believe that one person than whatever they had learned in the program. That's just the reality of how patients interact with information. So I think that the only way to, educating patients is important, educating as much of the people that are involved with the care is important. I ultimately think you have to assign a goal. And the analogy I would use is the SKIP program, which, it didn't really achieve a whole lot probably in surgery, but it was something that was really successful and people got near 100% achievement because it was a goal and everybody could work towards that goal. So I think with clinical practice guidelines with opioids, the reason why I would make them associated with MIPS or bundle payments, whatever it is that we're doing, is when you establish and put them as part of the goal, then that's what creates the multidisciplinary efforts to achieve that goal. It's when it's left to every one of us to our own devices to do it. That's in my experience where it really doesn't work. And no matter how much information I give somebody, it only takes one other person to do that. And I was kind of laughing up here during the last talk because I actually received a text message from the spouse of a chair that I operated on yesterday to the total knee replacement. And it was that exact question. My therapist is telling me I have to take 2 Percocet before I go through the exact same question. So it's just this is what happens. And to be able to eradicate that is really challenging unless there's something that we're all trying to establish together, at least in my mind.
And I think nurses play a really important role as well. I mean, we've seen when opioids were part of our routine order set, nurses would approach the patient every 4 hours. Do you want to take an oxycodone? And so our quality improvement efforts really had to get the nurses involved and engaged with the issue in order to make headway. I think they play an important role, particularly in opioid use in the hospital.
Yeah, the oral surgeons are dealing with mainly outpatients. One of the things that has really dampened the number of immediate release prescription opioids prescribed are the PDMP programs, prescription drug monitoring programs, where, and anytime you're contemplating prescribing an opioid, you're going to look that patient up. And it's not just to look, and Rosemary taught me this, it's not just to look for doctor shoppers, but it's also to look for patients that are potentially on from different prescribers, unsafe combinations of drugs. They're on benzos, they're on an antidepressant, they're on opioids, and also we can talk about the magic numbers of 50 and 90 morphine milliequivalents. By the way, in oral surgery and dental medicine, we don't deal with that. Okay, we've never dealt with morphine milliequivalents. I mean, I deal with it, but that's not something that's dealt with typically in clinical practice. But now, Big Brother can see, you're the other practitioners, other healthcare professionals now can also see what you're prescribing based on the PDMPs. I think the state of Missouri is the only state that hasn't adopted it yet, although they are using it in St. Louis.
So I think that if anybody doesn't have any other questions, I guess I want to just make sure the panel, is there any topic about perioperative or postoperative care that you feel like we haven't addressed that might help inform a clinical practice guideline?
Yeah, I'd like to mention one thing, and again, I didn't have time to show this data. One of the things, and I know it's been promoted in orthopedic surgery too, is liposomal bupivacaine, Exparel. Even though it's got, the FDA was kind to Pacira Pharmaceuticals that they consider an extraction socket a surgical wound, but the data is pretty dismal in post-surgical dental pain, and that vial, like 10 mils of, now the advantage, if it worked, of liposomal bupivacaine is you can infiltrate into the site. The study I showed you for the mandibular teeth with regular Marcaine, you got to give block injections, which means their lip and tongue is also going to be numb for 9 to 10 hours. But those 4 cylinders, or what we call cartridges of Marcaine, they cost $5 total. 10 mils of liposomal bupivacaine is $150 to $175. So at least in post-surgical dental pain, liposomal formulations of bupivacaine, the results have not been overwhelming. I know it's looked better in abdominal surgery pain and things like that, but not for post-surgical dental pain.
Dr. Chow.
I thought there was just maybe time for one more question. So I'm curious about these challenging patients who have chronic pain history before they come in for their acute problem, and maybe on opioids or may have even substance use history. And is it kind of, is this a population that it's feasible to develop these types of dosing duration guidelines for, or is this just a group that is, so kind of complicated, they're kind of out of the, it's very it would be very difficult to standardize approaches. So
I'm happy to speak about obstetric patients in that context. I think the challenge is that there's virtually no data. I mean, we know these patients are challenging and they sometimes have difficult to control pain, but we have virtually nothing in the literature to inform how to manage them afterwards and the risks associated with different dosing strategies. So I think it's an important area. I think the evidence is not there yet.
I'd say the same for us. We've tried to do, for example, opioid holidays, and so we do drug screening prior to the procedure, and between 60 and 70% of the patients still have opiates in their body. So even when we try, it doesn't work. The only other thing, if I can just add one additional thing, I think as you look at your framework for guidelines and my guideline work, I think that the only group of stakeholders that opioids doesn't affect significantly but need to be at the table are the payers. At least in my experience in orthopedics, it's a kind of I alluded to it. The payers don't see a whole lot of downside to opioids, really, because what happens is a patient loses their job and then they're not part of the insurance company. They're not picking up anything after that, so they don't really see it the way that we all see it. So I think having payers as part of the process, as part of a guideline framework moving forward, and especially the big payer, Medicare, I think is really important moving forward.
And maybe I'll make one more comment about the framework. So one of the intermediate endpoints described in the framework is persistent opioid use, and we've certainly seen a lot of studies in recent years looking at acute prescribing and persistent use. I think one of the challenges in interpreting that literature is that there's no commonly accepted definition of persistent use. There's not been good validation work looking at patterns of persistent use that are associated with harm. I was involved with a study that was done at the University of Toronto by Hannah Wunsch, and she and her colleagues cataloged all of the different definitions for persistent use that have been described for surgery. There were 30 different definitions in the literature, and then they applied those definitions to a cohort of patients having surgery in Ontario and saw about 100-fold variation between the lowest estimate of persistent use and the top estimate. And I think a lot of what's being measured, particularly in these cross-sectional assessments of persistent use, is probably opioid use completely unrelated to the surgery. So that's an area where I think there's a real need for research if we're going to use that as an endpoint to develop evidence around potential harms.
Yeah, and I'd like to mention there's one study that I didn't show here that we did with emergency room docs from Presbyterian Hospital, which is part of Penn, which we published. It's been already cited in a couple of years, like 57 times. But it was actually performed just before the mandatory PDMP came into existence. And what we found was that the oral surgeons, a group of oral surgeons in the faculty practice, 90% of them were routinely prescribing NSAIDs. But they were also, for the worst case scenario, again, these patients are still numb. This is not an Elliott study. An Elliott study, I wait until the numbness wears off and they have moderate to severe pain. They were getting an average of 20 to 25 Vicodin or Percocets, and we found that there was an average of 13 leftover pills. So I think, while I'd like to think it's people like myself and Paul Moore and people who have spoken today that are making the major impact on reducing opioids, I think we're having some impact on our publications and our presentations. I think the PDMP now is playing a big role in reducing prescription opioids, whether the clinicians read the evidence-based data or not.
Well, thank you, everybody. I think that concludes our morning.